Okay, hello everyone. I'm instructor Muriel Howard, and we are going into week 2 of BC 3030. Here is our simplistic roadmap, and remember, you always have to get a real full and complete roadmap from your week 2 materials folder. What I have here is just a list of assignments that need to be completed, excuse me. We're working on week 2, the next step. While you're reading chapter 9, um, you have an assignment to complete that's worth 30 points. So if you do that simultaneously, you should be able to gather enough information to give you a heads up on the respiratory system discussion. This week, the discussion will require a little bit more research, so remember to include your references and never copy and paste anything word from word off of any website or journal or article, because you won't receive credit for that. Remember, complete your certification assignment. I believe this week is the CCS certification, which is worth 40 points. Remember, these are free points. There's 3 weeks worth. You have basically 120 points possible for this assignment. Just assure that you capture the exact information needed for the certification requirements and qualifications. Remember, print out and practice your next step test before completing it in the classroom. If you are not sure how to complete the next step test or your regular week 2 test, take a look at the Welcome to BC 3030 video. I will save a copy, or I have saved a copy inside of week 2 as well, so that you guys don't have to look around for it. Remember to print and complete your coding test while viewing the Breaking Down Coding Cases video, where I cover between 3 to 5 of the coding test cases and give you hints and tips on what to look for and what's important. Remember, you have your IEHR assignments on the Connect website. This is worth 40 points every week. And if you are having trouble with that, be sure to review the troubleshooting IEHR. There is also a copy of a video for that inside of the IEHR website for the weekly assignments. You should see a link at the bottom. So pay attention to that and reach out to me right away if you're having issues that need support or resolution, and I can help you as well. And do not forget your 2 replies to either myself or your classmates. Here are the list of tools needed. You need your Breaking Down Coding Cases lecture if you are having trouble with coding. You need the IEHR troubleshooting tutorial if you run into problems. And remember, always make use of the MBC tutoring labs. The calendar is listed inside of the Ask Your Coach discussion forum, and there will also be some additional information inside of week 2 instructor materials this week. So make sure that you click around for your resources. Never know how much information is available to help if you are not looking for it. It's a lot of help available. Okay, so we're going to begin. Chapter 9 covers the respiratory system guidelines. This is an interesting topic this week. I particularly enjoy the respiratory system. Here's the respiratory system at a glance. Remember, you can always search or Google a respiratory diagram to search one online. There's always going to be a diagram inside of the weekly instructor materials folder, but if you don't like that diagram, you can always look online for another one. So here we have our system. It's always important to know your anatomy, physiology, and medical terminology. because that marks the difference between coding on a mediocre level and a perfectionist. Perfectionist is always aware of the systems that they're coding. So you have your larynx and your pharynx. And one of the things you're going to learn this week is that the respiratory system works cohesively with your cardiovascular system. So as you can see here, you have right and left lungs, right and left bronchus. And so that tells us as a coder that the respiratory system can be coded bilaterally. So those are things to pay attention to when you're doing your case. If it's a left done on the left side, remember you need your LT modifier. If it's done on the right side, you need your RT modifier. So we're going to go over some of these rules as we continue on this week, or the entire week, because the discussion forum will offer a little bit more information as well. So here we are in the threes, and once again, respiratory and cardiovascular go hand in hand. So your cardiovascular system are also in the threes, a higher range, because they work together. So you have your anatomical divisions and subheadings, and the examples is that it begins with the nose, just like our diagram shows us. It begins with the nose and pretty much ends, I would like to say, in the lungs or the alveolar sacs. That's kind of not true, because the heart plays an important role in that as well. There's going to be a video at the end of this presentation that gives you a very good idea of how the system works. So you have your accessory sinuses, it's the second portion, and then the larynx, and it continues on until you get to your lungs and your alveolar sacs. So you have your subheadings. They usually include incision, which is to cut into, and excision, which is to cut and take out, as you can see the EX in front. Introduction, which basically means using a needle and inserting into. These are also considered percutaneous or done percutaneously. Endoscopic, which is one of my favorite. Repair, anything that's broken can be repaired. Destruction, as in tumors and lesions, and then other procedures. So we're going to go ahead and talk about tracheostomy. We have your trachea and the OS, and tomy means to create an opening. OS is the medical prefix for creating an opening, and tomy or tome is to cut, or the process of cutting. We have a couple of different types. We have planned, and we also have emergency. And as you can see, we have a couple of different codes inside of the plan. The 31601 is for a child under the age of 5. So what's important to know is that when we're coding this, we have to pay attention to the patient's age, whether or not it was planned or if it was an emergency. And you know, an emergency is when, for instance, a person is choking or they have a foreign object lodged in their throat, so they have to do an emergency or create an opening. We have a couple of approaches. We have transtracheal, which is cutting across the trachea, and then you have your cricothyroid, and we're going to look at the respiratory system to pay attention to that. Right across here, that's transtracheal, and then behind here you have your cricothyroidic membrane. So once you become really savvy and used to medical terminology and anatomy, the other alternative term for this procedure is cricothyrotomy. Just pretty much the same thing. You're going to find the exact same CPT code in the CPT index if you look it up that way. So once again, pay attention to the age of the patient. So what it's telling us here is that we have two types of tracheostomies that can be performed: planned, when the person is already scheduled for the surgery; emergency, we know when that happens. Of course, you have a different code range for that, and that the age of the patient makes a difference. And it doesn't really make a difference about the approach. We'll notice that it doesn't really mention a lot about the approach in our CPT manual. So what's considered in a planned procedure is the age of the patient, once again. Okay, so we're at a reflection point. Is a tracheostomy an emergency procedure? So that's something that we just discussed, and I know you guys know the answer to that. Okay, moving on. Endoscopic procedures. These procedures are done using a scope to view. Endo basically means inner or innermost, and we're going to talk a little bit about how we determine which type of endoscopic procedure was done in just a little bit. So it's use of a scope. These services are less invasive because the person does not have to be cut or in stitches given. There's less recovery time. Well, I'm going to take that back. They do have to be cut for an endoscopic procedure, but there's just a little puncture wide enough for the scope to pass through. And when there's procedures that are done in the respiratory system, a lot of times they can pass the scope through the nasal cavity or the mouth. So one of the rules is report the furthest point to which the scope is passed. And let's go over that. I'm going to go back to respiratory. So let's just say, for instance, the services do not mention exactly what procedure was rendered. And in that case, we have to kind of read the notes and pay attention to the scenario in our case. And they may say something like the scope was passed through the mouth or through the nose. Then they may say the pharynx and the larynx was viewed, and then it passed through the trachea over to the left bronchus, and then the left bronchus was viewed. At this point, even though he's mentioning all of these other sections of the respiratory system that was viewed, what we would report is the furthest point to which the scope has passed in the last portion that it was viewed. So in this case, our endoscopic procedure will now be known as a bronchoscopy. Remember, even if the service does not say a bronchoscopy was done, we will still report that it is a bronchoscopy. We'll begin searching for that in the CPT index because that is where the furthest point of the scope has been passed. And that's a little hint and tip for this type of coding in the respiratory system. You may have some cases in your chapter that are described such as that, but don't get discouraged. So if you're looking around and you see a lot of these extra words, just pay attention to the last thing that actually happened to the patient. And in this case, since they're just looking and viewing, then that would be a diagnostic bronchoscopy. And then if it turns into a surgical procedure, then we'll code it as a bronchoscopic whatever type of surgery that it was. And we'll have a couple of examples in our breaking down coding cases where we're going over the test questions this week as well. So we're at a reflection point. It tells us that there are many bundled procedures in the respiratory codes. Do not unbundle services that can be reported with one code. So that is a note and a hint and a tip, and I'll explain a little bit more about that when we talk about the thoracentesis. So we have thoraco or thoracic, meaning pertaining to the chest. or the thoracic cavity. And then centesis is to puncture and remove fluid, or it can also mean an injection. And in this case, since we're dealing with the thoracic cavity, um, it is to withdraw fluid. So this will be withdrawing fluid from the pleural space. This may be necessary for conditions such as congestive heart failure, pneumonia, anything that causes the thoracic cavity or the pleural cavity to fill up with fluid, such as pneumonia. And once again, I'll go back. It's always good to pay attention. So this area around each lung, that's considered the pleural space. This is a sac around the lungs. Each lung and the heart, most of your organs, are encased in a sac. And this sac is a sac of fluid. But there are times when the lungs may produce extra fluid in cases of pneumonia, and the patient could be having a sense of drowning. So in that case, let me go back to my other slide. So in that case, the providers will usually puncture and aspirate, or they can leave a drainage tube in place. Now, here's a scenario where you could run into a question of whether or not you would be coding for the drainage tube. So you're reading the chart notes, and then you run into all of these other words and services that seem as if they're going to be billed separately, or you're going to have multiple procedure codes. Remember that these things, the drainage tube is included in the service, and it is not reported separately. So that's why it's important to read your parenthetical notes up under each procedure that you're coding to determine if and when you can add a different code or component codes onto the service. So now we're dealing with respiratory services in the medicine section. We have a code range here for pulmonary services. We have inhalation and bronchial challenge testing. It's just telling us what it is and the code range for it. Some of your cases in the chapter will go over some of these and have you code them for practice. Some of the services that are inside of the respiratory subsections are the types of services rather are therapeutic and diagnostic. And the examples is the aerosol inhalation for treatment of pneumonia. This would be considered a therapeutic service because it's treating a condition, basically giving the patient therapy. And then we have spirometry, which is diagnostic to determine the lung capacity of a patient, the airflow. And here we're at a reflection point. What category of codes are used in the pulmonary subsection of the CPT manual? Once again, those are, well, I'm not supposed to tell you, but they're diagnostic and therapeutic. So here's some more information about spirometry. What it does is it measures breathing capacity. And the name of the actual record or report that comes out of the machine is a spirogram. And the word spirometry is to measure, or the process of measuring breathing capacity. It's also used as therapy, usually performed by a technician under the supervision of a physician. So these are some services that are done in the office, and in that case there is no technical and professional component with that. There's usually a global service that is done. There are times when it is done in the hospital as well, but it will be coded as a global without any modifiers for the hospital itself. They have some that are patient initiated, basically some types of machines that have a teletransmission from the patient's home to the laboratory so that they can continue to get the results and the patient does not have to stay in the hospital or the doctor's office. So one of our last reflection point questions is asking, what does spirometry measure and who usually performs the spirometry? So those are some things that I just covered, and you can always go back, or there's a copy of this presentation inside of week 2 instructor materials for you all to download just in case. So we have some other information about spirometry. When you review the chapter, you'll see that there's various types. There's a lot of different types of spirometry. Here's one that has or measures the speed of exhalation. Some of the key words you'll see is the peak expiratory flow rate, which is a PEFR. Sometimes it's called a PFR. And then you have the other type, which is a total lung capacity. And it has the volume of air lungs. Well, it measures the volume that the air lungs will hold. And let me go back, because when you're doing these examples in the chapter, pay attention to the wording. In the text where those examples are, they're going to give you a lot of different code ranges. As you can see, we would go from the 94010. Let me go back. Can't. Let me see. 94010 through 94070. So you have about 6 different types of services for the spirometry. If you get confused, just pay attention to the wording and match up the wording inside of the case. For instance, flow rate and things like that with the examples that's on the page inside of those little paragraphs. They have the heading with the type of service, and it also has the name of the test and the code that it goes with. If you need help with that, don't hesitate to give me a call or email me. Okay, moving on to sleep study. This is used in the diagnosis of sleep disorders. For instance, sleep apnea, where a patient or a person will stop breathing or cannot breathe, or basically their heart stops while they're asleep. The patient has to be asleep for a period of 6 or more hours to get a full study. This is conducted in a laboratory, and it tells us here that the parameters in the medical record and direct code choice, pretty much saying that the sleep study parameters will determine your code assignment. As you can see, there's approximately 12 different types of sleep study codes that we will run into. The term, or the medical term or main term for sleep study, besides sleep study, is also a somnogram or somnography. And if it's measuring variables or a lot of different types of capacities of sleep, or if it's studying multiple things, then that service is called a polysomnography, because the word poly basically means many, more than one, more than two actually. So some of those parameters could be electrocardiogram or an EKG, airflow, ventilation and respiration effort, gas exchanges, extremity and muscle activity, snoring, and other parameters that are listed inside of the CPT. So one of the things about the case is that just pay attention to the wording in the case and match it up to the codes that you find. Okay, last but not least, this is going to tell us what a bronchospasm is, and then after this there's a short video going over the respiratory system, and that should be the end of the presentation. So a bronchospasm is constriction of an airway or airway. An example would be that a patient has asthma or any other type of bronchial or respiratory problems that a person could have, like emphysema, bronchitis. And then there are some bronchospasms that are provoked by administrations of agents like a histamine. That's why some patients are on antihistamines. And then you have methacholine. And it says measurements of changes in breathing capacity. Well, you're going to go back. These particular agents that provoke bronchospasms allow the provider to have measurements in breathing capacity.
The process of exchanging gases between the atmosphere and the body's cells is called respiration and involves several events, including breathing. As we zoom into the body, we can observe the respiratory system during gas exchange. Air passes through the alveolar sacs to the alveoli, where gas exchange occurs. In this cutaway view of an alveolar sac and its capillary bed, the process of gas exchange is easily observed. During inspiration, atmosphere air fills the alveoli and gas exchange occurs between the alveolar and capillary epithelia. Oxygen in inspired air is represented as a white gas. Carbon dioxide in expired air is represented as a blue gas. Notice the changing color in the red blood cells during gas exchange. Now let's zoom into a higher magnification view of gas exchange at the respiratory membrane. Red blood cells in the capillary adjacent to the alveolus release carbon dioxide and bind oxygen.